Okay, it is 8 o'clock, so we're just going to go ahead and get started. I am a different face today. I'm Caitlin Johnson. I'm one of the project managers for Avon. Kim usually does this introduction, but she is on a well-deserved vacation this morning. So I'm going to do my best to embody Kim today and introduce Dr. Schuler and then hand it over to him for this presentation. Like I said, I'm super excited about this presentation. Okay, so Dr. Schuler grew up in the Fort Collins area in Colorado. He served as an MP in the United States Army, and after his service, he attended Colorado State University, where he double majored in botany and zoology. He earned his doctorate in osteopathic medicine and a master's degree in healthcare administration from Des Moines University, which was followed by an internship of residency in emergency medicine at Michigan State University. His passion for addiction medicine began over a decade with his own recovery from alcoholism. He's trained at Harmony Foundation and has worked with addiction medicine specialists for the past 9 years. He is dual board certified in addiction and emergency medicine with a subspecialty in wilderness medicine, which makes a lot of sense for where he lives. Currently, he lives in, is it Lafayette or Lafayette?
Lafayette.
Lafayette, okay. Colorado with his wife and has 4 adult children. He is the medical director for inpatient addiction treatment at the Foundry in Steamboat, Mile High Recovery in Denver, and outpatient substance use disorder treatment and Thriver Health in Inglewood. He has also served as a medical director for several other addiction treatment facilities. When he has his free time, which doesn't sound like he has a whole lot, he enjoys gourmet cooking, traveling, and various outdoor activities in Colorado. That is a condensed version of his bio because he has a lot to share with us today. If you're interested in reading the rest of it, it'll be on our website. So I'm going to hand it over to you, Dr. Schuler.
Woohoo! Good morning, everybody. Speaking of travel, we got back about 3 weeks ago from a 3-week deep dive tour of Tuscany, Italy, and it was absolutely phenomenal.
Wow.
Yeah,
Wow.
amazing. So feel free, if you weren't here earlier as we were discussing, go ahead and jump in, ask any questions that you have, because if you have a question, likely somebody else does. Everybody's got my screen and you can hear me okay?
You're good.
Awesome. All right, I got the chat window open. So, here we are. The first time we talked about addiction in general and what it was, what happened in the brain. So, understanding we have a basic knowledge there. We'll do a few reminders of that, and then we'll delve into each of the individual groups of substances. I'm going to do them in alphabetical order because there's no real other order to do that. And my contact information is there, and I'll have it right at the end as well. So, all addictive substances have one thing in common, and that is that they alter our brain's dopamine structure. And if you remember, the dopamine structure is what tells us this is what's next for survival. We are motivated to do this next thing, whether it's to reproduce, eat, sleep, take shelter, etc. That's what it's for. And about 20% of the population, about 20% of the population is affected with this. So substances really aren't the problem. They just unlock the wiring problem that we have. There are a lot of different mechanisms by which these chemicals do this, but the result is the same. And the structure of the chemical is what denotes the function. And we'll talk about that a little bit as well. So not to belabor this, here's like one quick science slide. And every substance that we're going to talk about interacts with individual cells in our body. All cells have this, what's called a phospholipid bilayer. It's a sheet of phosphorus on the outside and the inside of the cell, and a fat layer in between. It's a wonderful membrane because nothing can get across it except for one thing. So it all works by these little channels that are built of protein that conduct in between. And any substance that's going to interact with us has to interact through one of those basic mechanisms, with the exception of alcohol, we'll talk about in a little bit. It just comes straight across this membrane. Now, when we talk about this care, there's a complete continuum of care. The upper part of this illustration shows us what we as an individual move through with the help of the continuum, like you folks. So the first thing is we have to identify things. Next, we have the harm reduction phase, stop them from harming themselves. Then we have treatment management, we move into recovery, and then there's long-term medical support. Down below, this is the Society of Addiction Medicine's care continuum here, going all the way from zero intervention up to medically managed intensive systems like in the ICU and everywhere in between. So, as I'd said before, the substance is what unlocks what is already there. Well, I'm having a little, there we go. So, for general treatment, we talked about this continuum. Everything that you see before you is everything that's required to give someone a complete continuum program of care. So we have to think about a lot of things: childcare services, family services, education, medical service, mental health services. Along with all those ancillary services, there's, intake and processing within there. There's the treatment plan, there's behavioral therapy, there's medical therapy, etc. And we're here to talk about this one little central part today. So we're taking one little spoke of a great big huge wheel that we're going to talk about here. Central to this, the most important thing, and I'll illustrate this again in a minute, is sober support groups. And it doesn't matter what that looks like. AA is not better than NA, is not better than Life Ring recovery. It doesn't matter. Getting in and around drug support and alcohol support gets you into drugs and alcohol. Getting in and around sober support gets you sober. And like every illness out there, the severity of the illness is what dictates the level of treatment. So all of these things are absolutely essential. And, especially in a medical lecture, we start thinking, okay, if somebody has this, then I'm going to prescribe that, and then we're done. Nowhere near done. Remember, there's a huge picture out there that needs to be fulfilled. The best book you can get on this, I introduced last time, but I want to remind you again, it's written by Paul Early, MD. He runs a physician's health program. He was the past president of Society of Addiction Medicine, and this book is called Recovery Mind Training. It comes with a skills manual, and it discusses all the domains of recovery. In other words, every part of the individual that you need to address in order to get long-term sustained recovery. So that's a highly encouraged read. And it's a paperback, and it's geared toward anybody, that may have doctorate type training, all the way to if you've had just a semester of biology, you'll be able to absorb this quite well. And Dr. Early is just an amazing writer, so it's very engaging. Whenever we're in the treatment continuum, the ASAM criteria is the standard of care. Yes, there is a book, but there's a computer software package that comes with it, and anybody who's doing placement should be very savvy with the Society of Addiction Medicine care. And it hits all of the things you need to know about multidimensional assessment. How do you individually treat somebody with, fixed endpoints of that, but yet how can you remain flexible? It's important to clarify sub goals out of long-term treatment goals, and there needs to be an interdisciplinary treatment approach. And of course, all of this is very outcome focused. What does the research say? And remember, every single one of our clients or patients will not only be traumatized, but deeply traumatized. We all have trauma, and there are a number of things we can do to work with that. There's CBT, DBT, EMDR, exposure therapy, and the research is just beginning on rapid resolution therapy. I've highlighted that kind of in a white down here. I'd encourage you to go online and kind of Google the a rapid resolution therapy, because it's probably the quickest and most effective way of dealing with both single event trauma and long-term trauma. So when it comes to general treatment medically, what we are talking about is how much of an effect can we have by doing these medical interventions today? First of all, we could just do nothing, right? And less than 5% of people will spontaneously seem to recover. That number is very minuscule depending on the study that you read. Professional counseling that gives us a 5 to 8% increased chance of staying in long-term recovery. Professional groups and facilitation of those, another 5 to 8%. Pharmacotherapy, like what we're talking about today, only adds another 5 to 8% chance of staying in long-term recovery. And then here, if you take a look at this, any peer support groups, AA, NA, Life Ring Recovery, if you hit and stick, wow, that's a 40 to 60% chance. And take a look at this. What does it cost? Nothing. So this is absolutely crucial. Another thing to talk about before we launch into this, the substances themselves, is co-occurring mental disorders. There's about an 80% chance that there will be some mental disorder underlying that. Okay, maybe something fairly straightforward like ADHD, some minor personality things too, flagrant bipolar disorder, psychosis, etc. I just saw a comment up here. I have a patient that goes every day to AA and credits this to his sobriety for the last 2 years. Yeah, he's hanging out with sober people. And when he has a problem in life or reaches a challenge, he gets a sober answer rather than, I better have another drink. And the proof is in the pudding. And there's been a ton of research done on that. Back to co-occurring disorders, this is absolutely crucial. You can't in the early um, you cannot, in the early phase of withdrawal, really determine things. The head is in a complete chemical crap storm of what's going on. Sometimes you have to get people through that phase before you can really evaluate. So let's not jump on with psychiatric medicines right off the bat, with the exception of people who are psychotic. You may need to do something right away with, but and we'll talk about those with the individual chemicals, but this is absolutely crucial. If we miss an underlying substance use disorder like bipolar, like ADHD, once we get a great continuum of treatment going, next thing you know, they relapsed. Why? They're trying to self-medicate to get their brain back to what they would consider normal. All right, without further ado, if there aren't any immediate questions, let's jump into these substances, shall we? Alcohol, again, alphabetical order. Alcohol starts with an A. We've known this and been documenting it for around 9,000 years. About 25% of our population qualifies for what are called binge drinkers. That's a lot. Genetically, there are two types of alcoholism, early onset and late onset, and the chemical structure explains its function. Ethanol is a very simple chemical with 2 carbons, 5 hydrogens, and a hydroxyl group over here. This carbon hydrogen part is what we call a carbohydrate chain. Yes, it's pretty short, but that is a fat-loving part. This hydroxyl group is a water-loving part. So alcohol has the qualities of both fats and waters, which has a special implication coming up momentarily here. Like all the others, it has an influence on our dopamine system. And remember that dopamine system tells us what's next for survival. It's just the mechanism of this is different from all the others. The end result is that gamma aminobutyric acid, or GABA, which is the brakes on our brain, gets enhanced. And then anything that stimulates our brain to move faster, pay attention, etc. So that would be like the adrenaline system and glutamate, that gets decreased. So anytime we remove alcohol, that syndrome of withdrawal is the opposite of that. We no longer have any brakes on the brain. And there's this catecholamine glutamate storm that's like a runaway freight train. This has deleterious effects, alcohol does, on absolutely every cell inside of the body. Now, How this works is just as I had mentioned before. It's sort of, in quotes, a bipolar chemical. As we had mentioned, the technical term is what's called the dipole moment, that part fat, part water. And as you can see in this top illustration here, what's happening is alcohol molecules are outside the cell and they just go right straight through the membrane. The water part matches up beautifully with the phosphorus part. The fat part matches up beautifully here. So it goes straight across a cell membrane. So the concentration of alcohol outside of a cell equals the concentration inside of the cell. In this next illustration to the bottom right, there are many entry points. We're talking about the nucleus accumbens and the ventral tegmental area. That is the main communication in our survival center. The ventral tegmental area releases dopamine. When it goes to the nucleus accumbens, that distributes it throughout the rest of the brain to say, hey, this next thing is important for survival. Alcohol then has direct entry at several different points, including the one place in the body, the VTA, where it slows GABA, the brakes on the brain. So it takes off the brakes on the dopamine system and allows dopamine to be released. It also crosses the membranes of every other cell in our body and causes problems that way. Alcohol is relatively rapidly absorbed when ingested. The half-life's about 4 or 5 hours. There's what's called a zero order kinetic, meaning we can't do anything to speed it up. Once you saturate the body system, it will metabolize at a fixed rate. And for somebody that's got enough alcohol in their system, it can last longer than 24 hours. So the fact that you stopped at 11 o'clock at night doesn't mean that you can necessarily drive at 8 o'clock in the morning. When we talk about the level of alcohol in somebody's body and how well they can move, do tasks, etc., that correlates fairly well with impairment technically. However, the toxic levels, where you are intoxicated or where you have problems, is really poor. I've seen people absolutely passed out, can't take care of themselves at only 0.1%. I've seen others up walking and talking and doing just fine at 0.5% or 5 times that. Keep in mind, we can test for direct levels. What's this person's alcohol level? It's a 0.13. We can get a few days worth of information here through testing ethinyl glucuronide, ethinyl succinate, phosphatidylethanolamine. Those are all tests that let us know what's happened in the past 4 or 5 days. And also, if we check the body's metabolism as it begins to move out of the way to take this new priority that's come in, there are often changes in our liver enzymes, changes in ancillary liver products like our coagulative proteins, our PT, PTT. And in the CBC, generally for the long-term heavy drinker, we'll see an increase in the mean cell volume, and that comes from a vitamin B deficiency. Alcohol is absolutely huge. As far as substance use disorders go, it is absolutely number one. Down here in the far right, the cost to society is about $5.5 billion, or half of almost $1 trillion. I don't know what that number means. All I know is that there are a whole lot of zeros there. Alcohol and drug use, of course, way up in the top if we look at all substance use disorders. And then when we combine it, of those 16 million that have substance use disorder, about 12% or so will have it combined with something else. So whenever we have alcohol on board, we need to start thinking, could there be something else on board that I need to watch out for? Now, in the acute intoxication phase, like many other things, it's strictly supportive care. We have to pay particular attention to supporting the airway. If the person is not protecting their airway well, they need to be in the emergency department. The main thing is if they throw up and that gets into their lungs, that's pretty well going to end their lives. And so the other antiemetics, Reglan happens to be a favorite of mine if Zofran doesn't work. The beauty of Zofran or ondansetron is it goes right to what we call the chemoreceptor trigger zone in the brain, otherwise affectionately known as the puke center. Alcohol and benzodiazepines are only one of two fatal withdrawal syndromes that themselves can cause that. Now, yes, there are people that have come down off of opioids that have had underlying coronary artery disease, and it has triggered that. But alcohol withdrawal in and of itself is extremely dangerous, as is benzodiazepine withdrawal. And you have to really watch this. Yes, the theory is that by 10 days, your seizure window should be over, but I have seen seizures happen up to a month out, for no apparent reason with no history of seizure disorder. So hydration is really important. These people have washed water out of their system. They're going to have electrolyte problems. They're going to have, in general, B vitamin problems, especially thiamine and folate, which are absolutely essential for good brain function. If you're inpatient at a substance use uh, disorder treatment facility, the order in which you want to use withdrawal medications is the order that I've put them in down here. So clonidine is number one. That goes straight in to the cholinergic, the catecholamine storm up in the brain and helps tone that down. Gabapentin next, that helps tone down the nervous system altogether. Hydroxyzine is an antihistamine that just helps slow you down. You're using a side effect of it being tired. Barbiturates are absolutely wonderful to help with this, but you have to have oxygen monitoring, and I'll explain that in a different class coming up here in a moment. And then benzodiazepines. And you say, well, gosh, in the outpatient setting, benzodiazepines would be first, or the emergency department. Why don't I just pile those babies right on board? Benzodiazepines are what is known in our group as solid alcohol, and people with alcohol use disorder absolutely love benzodiazepines. So I use them only when I have to, only for patient safety, and I minimize the use of them. Otherwise, we're going to have some real problems getting them off. In the outpatient or emergency department setting, benzodiazepines being the most effective. In the outpatient setting, a prescription for a couple of pills to get you over the hump, to get you through till tomorrow, because we're going to keep a sharp eye on you. In the emergency department, go ahead and use those first, followed by the other two. And then in the, of course, barbiturates only in the emergency department setting. Never send somebody out the door to try to get them converted onto barbiturates for the long-term withdrawal. Barbiturates have a very long half-life, on the order of 4 to 5 days. So by the time you load somebody up and you test their urine 30 days later, you'll say barbiturates, but they didn't get those but way back in detox. Yeah, so that's the beauty. It will way outlast the alcohol influence in your body and slowly let go of those GABA receptors. So it's a beautiful transition to make. Now, once you get alcohol out of the system, all of these people will crave alcohol, just like we do our other uses, our other substances. So what can we do about that? A camprosate is absolutely wonderful. Here's a real problem. You got to take 2 pills 3 times a day. What's it like trying to get your patients to take 1 pill a day? Holy cripes. So keep that in mind. Only the most adherent patient will do a camprosate, but if they are and they're compliant, it will work very well. As far as muscle relaxers go and other things we can do, baclofen is my favorite. It works directly through the GABA receptor. It can be abused, but if you're going to help with cravings and people are having muscle spasms, etc., baclofen's wonderful. All of the anti-seizure agents can really help stabilize the brain, can help reduce the craving. None of the studies have been super good, but as an add-on agent, carbamazepine, probably my first choice. Divalproic acid or divalproex may be a little more toxic. Topiramate's actually pretty good, but boy, you have to be really careful and uptitrate people fairly slowly. Antabuse or disulfiram, it's not actually an anti-craving agent, but we put it in here because we see it used occasionally. It's an aldehyde dehydrogenase. The first step of alcohol metabolism is you turn it into aldehyde, much like formaldehyde, only it's ethaldehyde, and it's extremely toxic. Aldehydes are preservatives. Well, you don't want a preservative in your liver or the rest of your body. And so it interrupts that, causes a buildup of this poison and makes you sick. This is purely punitive. Well, remember, I told you, everybody, just by virtue of having this illness, is going to be punishing themselves. Oh, I should do better. God, I'm the lowest. I mean, this is, I'm awful. Subsequently, adding more punishment is really not effective. So if you find that you're in a corner and you must use it, and the threat that it's there and that the person might make themselves sick is helpful, start really low and go slow. And I kind of like an idea of, a maximum of 250 milligrams. You'll get less liver side effects with it. And I'm not talking about with alcohol, but it poisons the liver all on its own. Other things go through the same metabolic pathway. Those things can build up. So I've seen a lot of ant abuse problems just for the sake of ant abuse, not with alcohol. Because it's alphabetical in order, naltrexone, I mentioned last, it's an opioid antagonist. And you say, well, opioids, aren't we talking about alcohol? It goes up to that opioid receptor and influences similar influence systems on our dopamine drive and tells them they're taken care of. So it's actually effective in a little over half the time. Now, because all opioids can cause problems, do an oral trial first. I like to start people, as I've listed here at the bottom, at about 25 milligrams. And you do that once a day. They'll usually have a little bit of nausea. You can add a little bit of an anti-nausea medicine if you'd like. After about 4 or 5 days, it goes away. Then you go up to the normal dose of 50 milligrams a day. If that works, and they tolerate the side effect profile, then you can do the injectable. Please don't ever do the injectable right off the bat thinking, well, they'll be protected for 30 days. Because if it doesn't work or they have bad side effects from it, they're going to have those side effects for 30 days. And I've had a few patients that people just started this right off the bat and they wound up in the hospital. One poor guy was in the hospital 3 separate times from a single injection. Any questions about alcohol before we move on to the next thing in the alphabet? Cannabinoids or cannabinoids, depending on which side of the Mississippi you're from. I'm not sure what is the correct pronunciation. You see both in dictionaries. Cannabinoids have been around for about 12,000 years, and we've got documented medicinal use going back 5,000 years. In the 18 to 25-year-old population, almost 40% of the United States population is using this regularly. Cannabinoids can be both plant-based and they can be synthetic. Endocannabinoids, those are the chemicals inside of our body. Those moderate neurotransmitter release. They sort of tell us out of the gas and the brakes that our neurotransmitter are, how much gas, how much brakes. CBD, cannabidiol, is one of the main constituents of these plants, and you've heard a lot about. It's the non-psychoactive component. We'll get to that in just a little bit. THC is the more psychoactive component. There are a bunch of other things in there, but they're so close to the middle as to whether they're psychoactive or not. They really don't matter in comparison. Up in the upper left of the illustration, this is your basic THC molecule, and you can see a whole bunch of different synthetic derivatives down below here. But if you sort of glaze your eyes over, you can see how they're all sort of similar to this basic progenitor molecule. When we smoke or vape these things, they're relatively rapidly taken up. There's also topical in forms and oral forms. It indirectly influences our dopamine system, meaning how much dopamine, and we get dopamine feedback. THC itself is not very powerful. When we put it on a cannabinoid receptor, it's only about 20% effective, yet some of those synthetic chemicals like bath salts that you've heard of and things like that can approach 100% effective. So even if we have a strong concentration of THC, we still don't have that much activity at the receptor. So we can really overwhelm those receptors with synthetics. This then, because it's a great regulator, has widespread activity throughout the body and through the brain with a whole bunch of different neurotransmitters. So we can have cognitive, psychopathologic, all kinds of psychomotor effects, since every system is done. And the current research is showing us that people who are predisposed to mental illness tend to prefer the reefer, right? So we've heard cannabinoid or cannabis induced psychosis, probably actually cannabinoid associated psychosis. So if somebody says, "Oh yeah, I love to smoke pot," I have to think mental illness, because that most likely is what is underlying that. Again, we talked about the two things. Here's CBD over on the left, THC over on the right. They are the most psychoactive, non-psychoactive parts. The others in the middle, really, we haven't found or identified much in the way of use for. And the way these work, as I'd mentioned, is ancillarily. So if we have a presynaptic neuron and it's going to do an output of something, that presynaptic neuron is moderated by the amount of CBD or THC that is within the system, or our own endocannabinoids that tell us how much gas and how much brake. And so that's the way these work. This is the great moderator of our nervous system. And of course, when we overwhelm it, we're overwhelming the moderation of our nervous system. So as I mentioned, when we smoke these things, they're pretty rapidly ingested, taken up in the order of minutes. Whereas when we ingest these things, depending on how much food there is in the stomach, other situations, the blood flow in the stomach, the absorption can be readily slow. And where we've gotten into trouble is people saying, "Wow, I ate that about 30 minutes ago and I'm not feeling anything. Maybe I'll eat more. Gosh, it's been an hour. I'm hardly feeling anything. Maybe I'll eat more." Next thing you know, it all catches up with them and they get into real trouble. Back when I was introduced to marijuana in the 1960s and 70s, the THC level in the plant material was anywhere from 2 to a maximum of about 6%. That was the good stuff. And it had a balancing CBD level of about 1 to 2%. Currently, the plant material ranges anywhere from 12 to around 45%. And what about the CBD level that helps create balance in there? Forget it. It's all been bred out. Zero, zip, zilch. Don't forget, waxes, dabs, and oils can get us up to 80% THC, and shatter, which is a chemically purified form, can give us 99.8% pure THC that we can pop into a pipe and smoke. The half-life of THC is extremely long. It's very, very lipophilic, stores up in fat, stores up in bone marrow, stores up in the fatty gunk within the lungs. And so people will test positive for THC literally for several months. It's not unusual to see heavy daily users still testing positive until the 3 or 4 month level. And unlike alcohol, levels in the blood correlate very poorly with impairment, which is why states are having a real hard time putting limits on that. We do have a number of medicinal uses for chemicals like dronabinol, nabilone. Most of those are CBD, not THC. THC does have one use, and that's in refractory seizures as an ancillary thing. There's a ton of research going on out there, and more about this. We're going to start seeing more widespread use of CBD in the hands of professionals. About 17 million adults use marijuana daily in the USA. About 55 million, so way over 10% of the population, have used this in the past year. If you're under the age of 12, then your incidence of having mental illness doubles if you're smoking marijuana. So if somebody said, "Oh yeah, I started smoking pot when I was 11," then you need to start thinking about mental illness. And about 6% of the high school seniors use marijuana daily. Over here is alcohol in the blue as far as substance use disorder. This is sort of divided up as to all the substance use disorders. THC is huge at about 45%. So we can't ignore this or be saying, "Yeah, it's just pot." For the acute intoxication phase, there's not really a whole lot to do. Sometimes people can be agitated. You might need to add a little benzodiazepine. The acute intoxication is much like nicotine withdrawal. Sometimes antiemetics are needed. Zofran's a favorite, and cannabis-induced hyperemesis gravidarum is prevalent. I see a question in the chat here saying, why has the CBD been removed from today's plants? It hasn't. What we have done is selected to get higher and higher THC. As we select for more and more THC, the CBD just happens to fall off. That's the product of selecting for one thing. We don't care about the other. And then, of course, there are some forms of the cannabis plants or the hemp plants that are specifically bred to get high concentrations of CBD, in which case there's almost no THC in those. But the stuff that you go to the pot store to buy will be very high in THC and no CBD. I hope that answers that question. So usually the acute intoxication phase of this is fairly rapid. As far as the withdrawal phase goes, there's not a whole lot there. About two things to really think about. Gabapentin is the main nerve stabilizer. It's very well tolerated. Since all the moderation of the nerves in all the systems has been affected, it's good to put something more general on board. So I like gabapentin. That's sort of frontline therapy. I haven't used it much, but dronabinol is a THC replacement, and you can go up to a maximum of 60 milligrams daily. That can help an early recovery. Typically, I would do sort of a taper off over a period of a week or 2 weeks with that. So you may get up as high as like 50 milligrams a day, and then you do that for 2 or 3 days, then 40 for 2 or 3 days, 30 for 2 or 3 days, 20, 10, just to help them kind of ease off of that. There are 0 FDA approved therapies, okay? So in teens, those under 18 and under, N-acetylcysteine available over the counter helps replace some things in the liver, and about 1,200 milligrams BID is very safe, well tolerated, and seems to be fairly effective in craving reduction. Once we move to the 18 and over group, it doesn't seem to work, and we have no clue why. Also, topiramate can help with that spontaneity, that gotta have it kind of thing, slow the brain down. But the side effects of topiramate are rather prevalent, so only if you have to add that. Contingency management's very effective, along with psychotherapy and that sort of thing. And we have to treat the underlying psychiatric illness. Remember, if you're a pot user, especially if you're a pot user early, wow, this is absolutely crucial that we treat underlying mental illness with sustainable measures. All right, on to the dissociatives and hallucinogens. Dissociatives we don't see a whole lot of, with one exception, ketamine. That's getting very popular out there. PCP has been taken off of the market. Hey, dextromethorphan, I've heard of that before. Yeah, it's in cough medicine. It's actually fairly popular and works at opioid receptors. Of course, the psychedelics we've all heard about, and there's a new synthetic out there, N-benzyl phenethylamine. Wow, no wonder why they call them N-bombs. Those are new. We'll be seeing those. And then things that have both activities like ibogaine, MDMA, salvia is a plant available out there. Most of these things work at serotonin receptors. This is a serotonin molecule up here. These are all the tryptamines down here that we find naturally occurring, and you can see how they very much look like serotonin here. The dissociative class works at a little different places. They are all synthetics up here, and there are some ergot molds and a few other things, but they all, if you sort of phase your eyes out, you go, okay, I can see how they'd work because they look a lot like serotonin. Every dissociative is a synthetic. There aren't any naturally occurring ones, and what they do is dissociate the physical self from the mental self, and their anesthetics at higher concentrations. Both dextromethorphan and PCP can cause serious vitamin B deficiencies, so test for those, replete those. And especially with PCP, we don't see it much, but they can get so agitated up and going, just like with MDMA, we can get acute rhabdomyolysis. And treating those, we can wind up with serotonin system. I'll talk about that a little more in just a second. The hallucinogens, we have both natural and synthetic forms of those, and they produce an altered state of consciousness, but you remain conscious, and they do alterations in mood, thought, perceptions, etc. A lot of this stuff will not show up on drug screens, so we have to test specifically and for those things, and otherwise we might wind up missing those. As we all know, research is burgeoning in this area with all kinds of things, and I'll talk about research in just a moment. How do these things work? A number of different ways. The dissociatives generally work. Here's an example: ketamine sitting right up here at the NMDA and AMPA receptors. The others, like LSD, psilocybin that we talked about, they work at serotonin receptors in the cell wall. MDMA is sort of a catch-all. It works both at serotonin receptors, and after it gets demethylated, works at the dopamine and norepinephrine receptors. So no wonder why we can have so many different things that happen with all of these. PCP has the longest half-life. It can actually take several weeks to get over. I'll mention that in just a second. But the half-life is about 21 hours. So sit on those people for a while. This is increasing in popularity here. One of the reasons they're so much used, especially the psychedelics out there, is they're perceived as safe, but just a single trip can actually be pretty frightening and mentally pretty devastating. And as you can see, they are on marijuana use is on the increase, and hallucinogen use is on the increase. And this line right up here tells us who is using this. This is the 18 to 25-year-old age group. And hallucinogens, if you look at the whole picture of addiction, about 6 million people here. And the reason it's increasing is because of all the research out here saying, hey, we're researching this and we're finding it's good for things. That's great in the hands for professionals that are doing appropriate testing in well-controlled situations. But what the addict hears is, my life will be better if I do hallucinogens. So off to the races they go. All right. We do have a number of medical uses. As I'd mentioned, ketamine is an anesthetic. It's used in psychiatric realms for depression, addiction, etc. The hallucinogens are all still experimental, but probably right around the corner for being authorized. MDMA is a pill form that has had some indications for things like PTSD treatment, methamphetamines like for weight loss, etc. And ibogaine is used in other countries for withdrawals, addictions, but there are lots of cardiac side effects with this. So we're going to be hearing a lot more about this, and we need to have informed discussion with our patients. As far as the intoxicated phase goes, you'll see this oddball eye rotatory nystagmus with PCP intoxication. I've only seen it a couple times in the emergency department. If they're serious enough, they should be in the emergency department. Otherwise, supportive care is all that's necessary in a calm, quiet environment. Remove as much external influence as you can. It's not unusual to get nausea, so a little Zofran is a good idea. And if they are truly psychotic from this, antipsychotics are okay, but be really careful with MDMA intoxication because of the serotonin transporters, and with the catecholamines, we can wind up with hyperthermia, seizures, or what's known as a serotonin syndrome. So if you test positive for that, really careful or avoid the antipsychotic classes. Generally, there's minimal withdrawal that happens with this. Most people are just fatigued. And there's a thing out there called hallucinogen persisting perception disorder, HPPD. That's a fancy name for flashbacks. This is not a withdrawal syndrome. This is actually what the brain has learned, and it comes back up as a memory. Any of the withdrawal things, clonidine, some benzodiazepines, and as I'd mentioned, antipsychotics can help. As far as the management goes, we don't have any FDA-approved medications, just like the cannabinoids, so we're sort of stuck there. Now, a number of the serotonin receptor moieties, especially psilocybin, can cause cardiac valvulopathies. People say, oh, psilocybin, it's natural. Well, guess what? Snake venom is natural too. So we're starting to see a whole lot of people that now through the 60s and 70s used a lot of psilocybin back then during the tune in, turn off, get high um, days, and now they're getting heart valve replacements. They did not have strep throat. And they don't have strep throat antibodies, and so these cardiac valvulopathies are due to the serotonin 3 and serotonin 8. What the hell are those binding in the cardiac valves that cause them to get crusty? So you don't want to miss those. All right, moving quickly on to nicotine, something we can actually do quite a bit about. You can smoke it, you can chew it, you can use it as a snuff. There are vape devices out there, oral and topical. Here's the chemical structure, and it's only important because it replicates another one of our neurotransmitters in our body, which is the whole acetylcholine, the nicotinic and muscarinic receptors there. Why do you think we call those nicotinic receptors? Because we discovered them first, not with neurotransmitters, but with nicotine. All right. This originated in South America, and there are both recreational and medicinal applications, and it's a main ingredient in a number of pesticides. It's an alkaloid that's produced in the nightshade family, so of course tobacco, but then, hey, here's some things. What about eggplant, peppers, potatoes, tomatoes? We'll find it in the leaves there, not really in the fruits. Nicotine is a stimulant, revs up all of our body's systems, and gives us a whole bunch of underlying health effects. Now, vaping, is that safer because we don't get all the side carcinogens in with smoke? Maybe. We don't have long-term research. Vaping's only been around for, consistently a little less than a decade. So it's going to take us 30 years to get 30-year studies. All right, the way this works, it's an agonist at the nicotinic receptor right on the dopamine system, and it just says send more dopamine in. This is why it's highly addictive, but it doesn't have other immediate side effects. And so this happens directly in the VTA. Smoking used to be, this shows what's happened over time. If we look at early 1900, not many smokers out there. And then it became very fashionable through advertising and reached a peak about 1960. And in 1964, the Surgeon General released its report, and it's been on a downhill decline since, but still about 12% of the population smokes. Every single body system is affected. And even though I mentioned alcohol is the number one for addiction, nicotine is number one for preventable disease. 1 in 5 deaths is attributed to the effects of nicotine and smoking. So we have a lot of work to do there. Now, medical treatment. The acute intoxication, not much to do there. It has a feedback effect of keeping people from doing too much. Nausea is usually the only thing. Nicotine replacement is the best way of doing this. We convert somebody from short-acting smoking vaping into long-acting patches. The real problem is to get people to stop, you have to have buy-in. The opioids are obvious. I had to go to the hospital 3 times for overdose this year. Alcohol, I got drunk, I got a DUI. Nobody smokes a 3rd cigarette and tries to jump off a tall building. Nobody creates problems by having just a single cigarette. So getting people to buy in is the most difficult part. I'm here to stop my alcohol, but this keeps the wheels of addiction going. And best is to do cessation of everything. That gives us the best outcomes. Support groups are very important. The most important thing is motivational interviewing to get the person motivated to stop. Nicotine replacement, about 7 milligrams per half pack smoked. Varenicline is very, very good. Start out low dose for a few days, and you put somebody on that for about 3 months. And then bupropion can help bolster dopamine for a period of about a year. And have everybody call the 1-800-QUIT line because it's excellent. Now, opioids. We spent quite a bit of time talking about opioids before. It's a class of drugs that comes out of the opium poppy, Papaver somniferum. It's dating all the way back to the 8th century, and there are numerous medical uses. We have all the natural things right up here, morphine, codeine, etc., partial synthetics to full synthetics down here. Had a very, very long history of this back to 5000 BC. We fought 2 opium wars over this. They really became popular after we started refining things and creating ways of hypodermically injecting things in about the 1800s. If you write somebody a prescription that's never had them before, there's about an 8% chance you're going to unlock addiction. How they work? A little bit like alcohol. There is an opioid neuron that sits right over the VTA system and modifies the amount of GABA, much like alcohol does, and tells us to release more dopamine. And so it's excitatory as far as dopamine goes through an inhibitory pathway, a little bit backwards. And otherwise, it reduces neurons' excitability, especially through GABA. That's no trick. Everybody has seen this little graphic here that shows the number of opioid overdose deaths. 2023 is slightly down. CDC came out with some prescribing guidelines at the interface of 2016 and 17. We had a bit of a hit down, and then fentanyl became popular, and boom, here we are. Supportive care for the acute intoxication. The airway is the number one things. We can reverse with naloxone, nalmefene. We've now seen double dose naloxone. We now have nalmefene, very long half-life. The research is extremely clear. Nothing is more effective than the standard 4 milligram intranasal dose. Try to get that as much to your population. In Colorado, we've saved thousands of lives. We do giveaway things all the time. It's available over the counter now, and so it's highly recommended that people carry this. Trainings are very, very easy to do. And while we're at this and we have somebody that we think is acutely intoxicated, it's really important to make sure we rule out other things. Could this be hypoglycemia that's causing this? Acidosis? Do they have a head injury? Is there some sort of fluid electrolyte problem? And other antiemetics are important as well, because these people tend to throw up, especially in the withdrawal phase. In the inpatient setting, clonidine, gabapentin, hydroxyzine, and use benzodiazepines last, because they're going to love those as well. Buprenorphine and methadone induction. There are lots of methods of doing this. That's a whole separate lecture. And if you want to come back and talk about all the induction methods, that's great. I don't care if it's standard induction. I like to use a sort of a Bernese method or a slow induction. The bottom line is, once you get buprenorphine on board, it's got a super long half-life. Keep on adding, never back away, never back away. In the outpatient setting, benzodiazepines can shift to first for a few days. Again, with all using the other medications. And with respect to buprenorphine, 8 to 16 milligrams is protective. Keep that number in mind. Over 16 might be required to get people initially covered and comfortable. Less than 8 milligrams, they're not covered, but they tend to feel well. So usually in the first year, I always keep people at 8 to 16 milligrams and get them over to the long-acting injectable that we'll talk about in just a second here. Naltrexone is available. It's a blocker. It doesn't work as well for craving. So after long-term stability is achieved, you can consider naltrexone. The long-acting injectables like Brixadi and Sublocade. I like Brixadi a little better. It's easier to inject. It doesn't hurt quite as much. You don't get as much of a lump at the injection site, but it doesn't matter. Whatever insurance will approve, get it on board. It is the gold standard now. Make sure you do oral first. They're stable on it, then move through the insurance process. There's a built-in taper. After about 4 doses, you can just stop. Well, why would you stop? I'll talk about that in a second. Secondarily, everybody that withdraws, they have pain. The Way Out is probably the best book on chronic pain. I'm not going to explain it now, but chronic pain is actually pain up in the brain. It's just not pain in the body. And so this needs to be treated through non-opioid strategy. How long do we do opioid management? Well, the research shows lifelong MAT has the best outcomes. you must have a strong or mitigating reason to stop. If you don't have a definitive plan, uh, I'm sorry, and patients all need to have a definitive plan to what to do, not if an opioid gets in your body. Well, what are you going to do if opioids get in? Oh, trust me, I'm never going to do that. No, when opioids, think about us as a collective group. What are the chances that some of us are going to slip and fall, break a wrist, need a surgical intervention, have to have a tooth taken out, and have to have an appendix removed? What about a hysterectomy, right? Opioids are going to get in our body again. So I highly recommend this book for anybody that's got pain-related things. Sedative hypnotics, there are lots of them out there. A couple of cautions. These are the Z drugs out here. They very much look like diazepam and all of the benzodiazepines. They work the same way. The true sedative hypnotics like the chloral hydrates, etc. These are all synthetic and uh, have the same effect, but look chemically very different. Watch out for soma and cyclobenzaprine. Avoid using those because of their strong GABA effects. I basically don't use these at all. And I don't believe other people should either. Chloral hydrate was a derivative of alcohol, first synthesized in 1869, and is used as an anesthetic agent, not really much anymore. Benzodiazepines is the main thing we're talking about here, and they came into being in about the 1950s, and we've discovered they are totally inappropriate in the long term. Benzodiazepine-induced neurologic dysfunction is now widely prevalent. There's a lot published on it. And since all of these work at the GABA receptor and enhance release, I'll talk about in just a few seconds, we have to be very careful. They're only indicated for short-term use on the order of about 2 weeks. And of course, we all know about the long-acting benzodiazepines that we see patients routinely on board with. Barbiturates increase the duration of opening of GABA to allow more chloride in. Benzodiazepines increase the frequency with which it opens. Barbiturates you can overdose on and stop breathing. With the benzodiazepines, you cannot. Basically, these enhance the brakes on the brain here. The peak of withdrawal onset is about 7 to 14 days. So you can't just say, oh, good, the storm is over soon. Scope of the problem, take a look right here. What state do you folks live in? These are the problem states where the most benzodiazepine prescriptions are written. 30% of overdoses involve benzodiazepines, and this is what's projected for what's going to happen with sedative hypnotic use up through 2030. So about 1% of Americans have misused benzos, and about 10% of the population has used a benzo prescription in the last year, and 5% have an ongoing prescription. So we got a real problem out here. What do we do about this? The greatest resource out there is the book right here, the Ashton Manual. There's actually relatively little research on how we get people off of these things. The best guideline I use is you taper 5 to 10% per week. This means it's going to take a few months. You may be able to get away with a rapid taper. People feel awful during this time, and there's absolutely nothing they can absorb as far as skills. So you go low and slow with this. You convert them over. There are lots of conversion tables. There are conversion calculators. Get them from whatever their short acting is over to a long acting. I prefer Valium because it comes in small tablets. It makes it easier for dose. You start with a weekly taper of 5%. As you taper down, that 5% becomes 10%, and then go back down to 5% again. And then you immediately start sourcing sustainable skills and medications. Last but not least is the stimulant class. If you take a look at dopamine right here, here's what the rest of the stimulants look at. And look at this list, and you're going to notice a lot of things that you've seen in there before. Dexmethamphetamine, armodafinil, modafinil, nicotine, the synthetic cathinones, phenylpropanolamine, phenylephrine, stuff that's available over the counter. Stimulants just speed up the body's system. Medically, they're used for obesity, narcolepsy, ADHD, depression. They are out there everywhere. first documented way back to 2500 BC. They've really become popular since the late 1800s, where they were sold in all kinds of tonics and things like that. What about caffeine? They work through a various number of mechanisms, but the dopamine system is it. Cocaine is a main blocker over here. Amphetamines get transported right into the cell. Ephedrine also modifies these things, and the methylxanthines work on the receiving cells here. The bottom line is they all increase dopamine by a very direct mechanism here. Look what's happening with our stimulant prescriptions. This is 2021, and we are still on the increase. As we know from my last little lecture, that doing the non-stimulant classes is actually the choice if you have to medicate ADD. Methamphetamine use was up 40% 2015 to 2019. It's now eclipsing fentanyl problems. Stimulant-related offenses are up 75%, and stimulant-related deaths, here we track right up through 18, and here's what's happened back in the during the COVID days. So up. This is a huge issue that's going on. Super challenging realm to treat. Contingency management is best, and that's not a medication, right? There is no high quality evidence. There are a ton of studies out there. All the studies are small. They have low power. What I like to do and what's shown is to do a combination of things. First things first, switch people over to a long acting stimulant and get them off of the up and down. The lots of stuff is being tested, like antibodies, receptor blockers, ketamine vaccines. So there will be things on the horizon. I realize I'm out of time, and I'm going to wrap up with just a couple things here and a little bit on urine drug testing here. You've gotten a whole course in addiction management here. So you can all pass the boards. So amphetamine and methamphetamine related psychosis can persist for months or can be permanent. Much like THC, we've discovered this can unlock underlying illness. Doesn't matter, you treat psychosis the same. What I like to do is get into motivational interviewing here, get them on the side of motivation, get them involved in a sober support group, do contingency management. Now, support any underlying psych or illnesses. Treat those things, psychiatric illnesses, just like you always would. Low dose, support the low dopamine with long-acting bupropion. Remember, short-acting bupropion is called poor man's cocaine, so I never use that. So I use a long-acting, and it can take a lot, up to 450 milligrams a day. I always add naltrexone. Maybe it's the placebo effect. Who knows? And I usually add topiramate. I start low and go very slow, and then I stop that if it's not helpful. Before there are any questions about that, I want to say just a couple words about drug testing. A UA is a urinalysis. We need to stop calling that. We test for kidney function there, urinary infections, and we're looking for metabolic things. A UDS is a urine drug screen. It's an enzyme-linked immunoassay. UDSs are highly sensitive, which means we have very few false negatives. That's good. That means we have a lot of false positives. These are all the cups and the strips that you're used to seeing. Remember, opioids, an opioid test strip will not pick up fentanyl. It will not pick up nitrazines, and lots of things can cross-react. Ibuprofen will show up as a barbiturate. Benadryl will show up as an opioid. Amphetamines will strike positive in the presence of any of these things that people might be on by prescription. So the only way to really tell is if you confirm that with mass spectrometry after chromatography here. You can confirm in two ways. The patient can confirm it, or the lab can confirm it. The lab will tell you exactly what that molecule is. So if you get an unexpected negative test, wait a minute, your buprenorphine should be positive. If the patient says, hell yeah, I'm making a lot of money selling it on the street, they've confirmed it. Okay, we need to do something different in our treatment plan. Or an unexpected positive result. Hey, there's cocaine in your urine. Well, of course there is. My brother stopped by. We did lines all afternoon. We don't need a confirmatory test there. But otherwise, other things can be involved, or the patient can deny, in which case we got to use a confirmatory test. And are your confirmations up to date with all the new chemical stuff? You have to call the lab. And the most important thing is you got to know your metabolites. Usually this stuff is printed on the reports, but if not, call the lab. These things are important because they give you telltale signs whether the patient is compliant or not. Whew! I need to take a breath. Okay, anybody, excuse me, questions, thoughts, concerns? As I'd mentioned at the beginning, please reach out to me. This is super complex stuff. I glossed over everything. That's my telephone number. That is my email. Please use those. I love it when people reach out and ask questions. That way I know we're getting good information out to have.
Dr. Schiller, I know we're a little over time, and I understand if people need to drop off. I have seen some people come off mute, so we may have questions. Do you have extra time?
I got all the time in the world. I do have a
Okay.
9:30 meeting an hour and a half from now that I have to attend, so I'm good.
Okay, so we do have time for questions if anyone wants to put something into the chat or if you want to come off mute.
Yes, I came in late. This is Mary Ann Hansen from the Department of Correction. Can I get a copy of these slides?
Yes, we are going to work on that. And I want to get my first slide presentation to you. It's, with all the colors and charts and everything, it's a big thing. So Jenny and I are going to work really hard on how we Dropbox it, whatever we do. We're going to try and get this information to you one way or another, maybe just in handout form or something like that. I don't know what that's going to look like, but we will make this available, and my phone number is available. And please, call, consult. If I can help your jail set up a program, I mean, there's no greater point of entry. I would absolutely love to sit on the phone via Zoom or whatever and help you with an excellent program in your jail.
Thank you.
We will be posting this recording probably by tomorrow on our website.
Okay.
And so that you will have access to it in that way.
And you said website, you educate me. I'm not sure what website that is.
Okay, I will drop a link in the chat. It's ABHI, ABHI network.org. And we have a webinar library that I will put in the chat right now.
Thank you.
I'm so glad you're on, Marianne. My husband's a probation officer, and I was texting him pictures of the drug testing stuff. And Dr. Schuler, I will be informing him that UA is the wrong way to say that because he says that all the time.
Right,
So
and
I will
especially in
make
the
sure.
inpatient setting where we have female patients, as you know, females have a predilection to more urinary tract infections than males. And then, somebody says, hey, what's the UA results, right? Well, now we're testing for something totally differently. So it's very important to be clear on our communications. And we use these slang terms, and boy, abbreviations and slang can get us into real trouble,
Sure can. For sure. Do we have any more questions? Anybody else wants to come off mute? Dr. Schuler's very friendly, as you can see.
Did you, I'm sorry, it's Mary Ann again. Did you mention Vivitrol? Because that's what we use at the Division of
Yes,
Community
I
Correction.
called it long-acting naltrexone, but there's
Okay.
only one out there. Yes, very effective in alcohol use disorder. Again, for opioids, I save it toward the end. If somebody's got a rock-solid program, they've had about a year of sobriety, and they want to convert over to that, I
Right.
think that's good. I really like the injectable, buprenorphine,
That-
because there's very little in the literature, but there are a few anecdotal cases, and I now have 3 personal cases. My longest has been off for 3 years, and there was absolutely zero withdrawal, no taper, no nothing. That
That's
stuff
great.
just comes out of the body so slowly that the body readjusts.
Right.
So, it's absolutely the gold standard. And if you're going to think I better do opioid support, then the ultimate goal should be to get them on a long-acting injectable.
Right. Thank you.
Of course.
All right, we're coming up on 10 after, so we may
Good
want to
morning.
go. Oh, go ahead.
Hey, be quiet, please. Good morning. Dr. Schuler, this presentation was fantastic. This is Tamika Ramsey. I'm a licensed master social worker in group therapy practice. And I just have a question because I have I don't know a whole bunch about addiction. That's not something that I have specifically studied. But I just find it interesting. I have a client who is 84 years old. He has been an alcoholic for the last 8 years. Grandson, be quiet, please. He has had some pretty severe health issues, ended up in the hospital, all those things, right?
Yeah.
Well, he's currently living in an assisted living temporarily. And the interesting thing that I'm working with he and his wife is that when he does not have access to alcohol, he doesn't appear to crave it. He's not an irritable person. He's not trying to get it. But if it's available, he will drink it, right? And if it's
Absolutely
available
right.
without,
And if you watch Tamika, my first little chat that I did with you guys about addiction, that's sort of a classic thing, right? I had mentioned 25% of the population makes binge drinkers. In other words, they're not craving, but every time they put alcohol in their system, it's always too much and they get wreckage. And so
yes,
that's the hard person to convince. Yeah, that stuff just doesn't belong in your body because it doesn't work, right? It's like having
sure.
a peanut allergy. Oh, I haven't had a peanut in 10 years. Let me try your peanut brittle. Well, sure enough, I'm going to have troubles, right?
Sure. So how do you, I guess I'm at a place where I mean, he says he's not an alcoholic, right?
Yeah.
And
This is
I'm at a
perfect for
loss.
sober support groups, Tamika. Get him in and around other people that have this thing. And I guarantee you in an AA room, where he's sitting with other people, somebody's going to say, oh yeah, that's exactly what mine is like, right? And then
Yeah,
he'll be able to say, really? Okay, I see where this is a problem. I'll moderate. And then the last time, he gets drunk again and didn't moderate. And
sure. Okay.
what else?
Okay. I don't want to interrupt anyone. I don't think I see anyone else off mute. So again, Dr. Schuler has put his contact information out there, encouraging you to email him. I'm sure he probably wouldn't ignore your call if you were to call him.
No,
So,
please do. I've
okay.
gotten several calls from the last chat.
Good. So, Dr. Schuler, we're so thankful that you were willing to talk with us today and give us some insight on addiction and how it works with our brain and the options for treatment in that. It's a pleasure hearing you speak every time. Like Jenny said, Jenny is our website guru. She's going to have this up probably the next day or so. And you can see Dr. Schuler's first presentation on there as well. She dropped it in the chat. But as always, thank you guys so much for coming to our monthly webinar series. You should be able to register for the ones we have going on via our website as well. And we will see you next month.